So my name is Ed Akelman. I'm the Chief of Microvascular Surgery and Upper Extremity Surgery here at Rhode Island Hospital and University Orthopedics. Was a product of a Brown search. Came up and looked at Rhode Island, loved the area, thought it was a great place to work, great institution. And so in 1985, I started working here at Rhode Island Hospital. So I've been here now 25 years. Well, there are a couple reasons why the hand. The first reason is my hand. And it turns out that I had a skate go over my palm when I was at Princeton, and a really nice plastic surgeon in Princeton, New Jersey, fixed me. And I had tendon injuries and a nerve injury. And as he explained what he was doing, I thought that was really great. The public, I think, doesn't understand that when you're in training and you're doing things to care for illnesses, that over the course of a lifetime as a physician, many of the treatment options and ways in which we treat people change. So probably half of the things I do on a day-to-day basis, caring for patients and doing surgery, is different than when I was a resident back in New Haven. You are constantly challenged to learn new things. And the great thing about University Orthopedics and our practice is that every day I'm working with young medical students from Brown. I'm working with young residents who are doctors in training from Brown and Rhode Island Hospital, where they're actually based. And then even fellows who are younger doctors who've done all their residency and then they're doing an extra year with us. So I have fellows who spend a year with me learning how to do hand surgery. And they're constantly asking questions about, why do you do this way? Have you thought about doing things that way? Where we used to use big incisions to do things in the hand and the wrist and the arm, we're now doing it through smaller incisions. We're trying different drugs. There's a condition that I treat called Dupuytren's contracture, which actually is a congenital condition or a genetic condition. You're born with it or you get it as you get older because you have genes that promote it. And what that does is that causes your finger to bend down such that you can't straighten it out. So for years, the only technique for that condition was actually going to be that you have an operation where you open the whole palm up. And now we use limited incision techniques. There's actually a new drug that's coming out on the market. It hasn't been FDA approved yet, but it's, here, for instance, we're able to do FDA trials. So I was able to participate in a phase 3 FDA trial with an injectable medicine. So it may be a condition that 25 years ago I would operate on with a big incision, and now I'm able to use an injectable medicine. What I want to make sure when you leave my office understanding is what the condition is, why do you get it, what are your options for treatment? And if you then leave with an understanding of that, you're going to be a better patient for me and for yourself. And so educating residents and medical students is really, to some extent, the same way we should educate patients. So I think that's the advantage. I learned to do that with medical students. So when you come in and see me, I'm basically teaching you as well. There's certain things that just shift and certain things that don't. One of the most common questions I get asked from people about this condition called carpal tunnel, which basically is a problem where the thumb, index, and middle finger are numb, pins and needles. Pins and needles basically means that your nerve is not working normally. Well, it turns out that George Phelan, who is a surgeon in Texas in the late 50s, described carpal tunnel. And there were no computer keyboards then, and there was no repetitive activity then. People got carpal tunnel syndrome generally because the size of their tunnel got smaller as they got older. Some of my best patient outcomes come from patients with carpal tunnel because the average patient comes in and says, Doc, I really just can't get a good night's rest. I can't sleep. Because patients with carpal tunnel syndrome generally wake up in the middle of the night shaking their hands out, fingers are numb, pain in their arms. And the reason why you get it or the pain you get is because you have ischemia or lack of oxygen in your nerve. What we really do is we make the nerve ischemia go away. And the first night that I treat those patients, their pain at night is better and they're sleeping better. And they think I'm wonderful because they're getting a good night's rest. When someone says, I want you to go see Dr. Akelman, the surgeon, the immediate transformation is, oh my word, I'm going to, because I must have surgery. And in most cases, throughout the spectrum of orthopedics that we take care of here, and especially in the hand, we treat things conservatively. So the average patient who comes in to a surgeon for carpal tunnel syndrome generally leaves with a splint to keep the wrist from bending to make their symptoms go away and doesn't have an operation. With 25 years of experience, I tell my patients that the reason why I get great outcomes is that when we're taking care of hand injuries, it's really a team. The team is the patient, the surgeon, and the hand therapist. We actually have certified hand therapists, and these are actually physical and occupational therapists who had special training the way I've had special training in hand surgery. And the advantage here is that in addition to having people with that kind of training and experience, they can come get me if they're concerned about anything where they're seeing a patient in the office. So it's very often that a therapist will walk over and say, would you mind coming over and seeing this? I'm not quite sure about this. There's just so many stories of good outcomes that I remember. The ones that are that are obvious is that if you come in and you've been working with a log splitter, and unfortunately you put your hand near the log splitter and the log splitter went off when it shouldn't have, and it took your hand off at the wrist, it's amazing to have the techniques now that we have here when you put a hand back on. So I've actually put hands back on in the 25 years I've been here. A young woman with an awful disease called rheumatoid arthritis. And rheumatoid arthritis affects the whole body. I've been told you can help me. It's so difficult for me. I can't lift my children anymore, and I'm in pain all the time. And once that joint was healed, to have her and her husband come in and tell me how much just the simple things of how she could take care of her children and how she could do things around her home and at work, it changed her whole life. And then people who come in and say, I can't sleep. And I see them 10 days later when I take their stitches out for this carpal tunnel surgery, and they say, you are so wonderful because I'm sleeping, and you have no idea how that has an impact on my life. So you go the spectrum of something that's a simple operation to a complex operation like putting a hand back on. All of those patients are happy because we're actually making them better. I think it's just as important to make a young mother able to lift her child as it is to put a hand back on. I say to my family that after doing this for 25 years, when I get up in the morning and I look in the mirror, I just love what I do.